Be talking about the significance of the TURNS project on mitomycin C for recurrent bladder neck contracture. This is a retrospective series where we looked at the outcomes for mitomycin C at TURNS centers used during bladder neck contracture release. First, we'll be talking about some background and then prior experience with mitomycin C, the TURNS experience with mitomycin C, and then we'll compare our outcomes with recent series of deep incision alone of bladder neck contracture. This is a representation of bladder neck contracture. It's usually iatrogenic following radical prostatectomy or radiation for cancer of the prostate, or TURP. The estimated incidence varies between 5.8 to 14%. This was based on a SEER Medicare study. In some cases, it can be recurrent and very recalcitrant to treatment. Bladder neck contracture can complicate the treatment of post-prostatectomy incontinence. It's also an independent risk factor for post-prostatectomy incontinence, and the patient and technical factors have been implicated in the development of bladder neck contracture. This is a paper from Memorial Sloan Kettering on 4,500 consecutive patients undergoing open and laparoscopic radical prostatectomy. There were several factors that predicted for bladder neck contracture: age, BMI, comorbid status, and then there was also some technical factors. Individual surgeons, estimated blood loss, and a postoperative urine leak hematoma were predictive of developing bladder neck contracture. These bladder neck contractures in this paper were shown to occur at a median of 3.5 months, or very early after prostatectomy. This is a table from another paper looking at risk factors for development of bladder neck contracture after prostatectomy. They found significant risk factors were smoking, coronary artery disease, hypertension, and diabetes mellitus. This underlines the fact that comorbid status certainly contributes to the development of bladder neck contracture. So the options for bladder neck contractures are endoscopic versus open reconstruction. Generally, it's thought that endoscopic incision of the bladder neck contracture has a fair to good success rate, and open reconstruction is reserved for cases of recalcitrant bladder neck contracture. Open reconstruction of the bladder neck is usually reserved for last resort. It can be done from the abdomen, as depicted here, where the symphysis pubis has been removed in order to make a vesico-urethral anastomosis. It can also be done perineally, where the urethra is freed and brought up to the bladder neck and reanastomosed. Generally, after prostatectomy at least, a simple YV-plasty is challenging to perform, given that the pubic bone sits right in the way of the reanastomosis. The long-term success rate of open reconstruction is approximately 70%, and urinary diversion may ultimately be needed. This is a table of the endoscopic management of prostatectomy of bladder neck contracture. It looks at the number of patients and the various techniques that were used for dilation or internal incision of the bladder neck contracture. The paper we want to highlight was recently published in 2011 from Leahy Clinic with Vanny and Buckley, and it looked at incision of the bladder neck contracture with mitomycin injection. They reported 72% patency at 12 months after a single procedure, and this raised to close to 80% or higher with 2 procedures with the injection of mitomycin as an adjunct. They looked specifically at 18 patients with recurrent bladder neck contracture and at least one prior transurethral incision of bladder neck. 56% of the patients had more than one. All were treated with cold knife incision and then had mitomycin injected, approximately 3 to 4 milligrams in the bladder neck. The median follow-up was 12 months and the range was 4 to 26, and follow-up was cystoscopic follow-up exclusively. 72% of the patients had stable bladder neck after one treatment and 89% after two treatments. So we looked at our own experience and the 8 contributing centers at this time to the Trauma and Urologic Reconstruction Network of Surgeons. We identified a total of 66 patients. The etiology of the patient's bladder neck contracture was varied. The vast majority arose from prostatectomy. TURP was the second leading cause, robotic prostatectomy, and then a variety of other factors. 80% of the patients had failed prior treatments for bladder neck contracture, so not all of them had failed more than one treatment. Prior radiation therapy was used in 25% of patients. The patients underwent a variety of surgical techniques for release of their bladder neck contracture, including cold knife incision, Collins knife with electrocautery, and transurethral resection of the scarred tissue. About 45% of the patients required placement of an artificial urinary sphincter after bladder neck contracture release. This is a summary of our experience with mitomycin C. Out of the 66 patients, we had follow-up in 55. The excluded patients included less than 3 months of follow-up or no cystoscopic follow-up at all in the postoperative period. Of the 55 patients, 58% had a stable bladder neck at a median follow-up time of 9.2 months. Recurrent strictures occurred in 42% of patients. The time to median recurrence was 3.7 months after failure. 27% of patients underwent a second transurethral incision of bladder neck with mitomycin C. And of these patients, we had an approximately 60% stabilization of the bladder neck. The median follow-up time for this series of patients was 8.6 months, so our cumulative success was 75%. This is less than the Leahy Clinic, where they achieved 75% within the first mitomycin C injection with cold knife incision of the bladder neck. Success over time, definitely in the first year, most of the patients dropped off that failed. Looking at the specific predictors of success and failure, we found that prior radiation therapy, surprisingly, did not predict a worse outcome. Likewise, radical retropubic prostatectomy did not predict success versus failure. And also, prior transurethral incision of bladder neck, those that had greater than or equal to 2 prior transurethral incisions had equal success to those that did not. The total dose of mitomycin C also did not predict success, either the concentration. The only predictor that we could find was hot knife incision with a Collins knife, which had an odds ratio of success of 10.7 over cold knife incision. There were several adverse events associated with mitomycin C, which are important to highlight. This was in 5% of the patients. A 63-year-old male who had bladder pain and non-healing ulcer, which extended from the inside incision to the trigone with a lot of necrosis of the bladder neck. He healed without evidence of stricture recurrence and no subsequent sequelae at approximately 6 to 9 months after the surgery. The next 2 patients also received approximately 4 milligrams of the drug. These patients developed much more severe complications. Osteitis pubis was observed in both patients, and ultimately both patients went on to urinary diversion. Our summary of this study is that 66 patients underwent a total of 90 injections, 55 with greater than 3 months of follow-up. We had 58% primary success and 75% after 2 procedures. Collins knife was more successful than other techniques, and 3 patients experienced serious adverse events. This represented approximately 5% of patients. Comparing our outcomes to deep incision alone, Morey published a paper from Texas in 2013. He had 50 patients, 78% had failed 1 prior transurethral incision of bladder neck. This is very comparable to our series. All were treated with deep lateral incision using a Collins knife. 72% achieved stable bladder neck after one procedure, and 86% after two, slightly better outcomes than we report with our mitomycin C injection. Whether all of these patients had cystoscopic follow-up, but as far as clinical follow-up, this is as good as our series. Another series was reported recently from Cleveland Clinic, looked at 63 patients treated with cold knife incision. They experienced a 51% primary success and a 70% primary after two procedures. Again, this is comparable outcomes to our 58% primary outcome and 75% secondary outcome with two procedures. And they also followed these patients clinically only instead of with cystoscopic follow-up. Another paper, which looked at recent outcomes from deep incision alone, was from Cleveland Clinic and reported in 2014. They looked at 63 patients, all treated with cold knife incision, and they had a 51% primary success and 70% success after two procedures. This is very comparable to our outcomes, where we had 58% success and 75% success after two procedures. The median follow-up was 11 months, but this was clinical follow-up, very similar to the Mori paper. In other words, these patients were not known to clinically fail with recurrent symptoms of bladder neck contracture and obstruction. It could be that in our series with strict cystoscopic follow-up, that our numbers represent a much greater success with mitomycin C, given that many men who have recurrent bladder neck contractures will not experience recurrent symptoms until the bladder neck contracture reaches 8 or 10 French or lower. Dealing with incontinence after bladder neck contracture release, it's really unknown where there's a safe interval to place artificial urinary sphincter. Incontinence is very prevalent in this population. In our series, we found that the mean time to recurrence was approximately 3 to 4 months. And so we hypothesized based on this that waiting about 3 months and finding an open bladder neck probably predicts a very good outcome, and an artificial urinary sphincter likely can be placed with minimal risk. We always consider placing a transcorporal artificial urinary sphincter in these cases. We feel the larger sphincter that's placed can allow additional manipulation of the bladder neck contracture in the future if it's needed. For instance, through a 5 centimeter artificial urinary sphincter, a flexible cystoscope can be placed, laser fiber can be used to incise a recurrent bladder neck contracture, and mitomycin could potentially be injected with a flexible needle. Future, we seek to define whether cold knife versus hot knife incision will prove to be a continued predictor of success. We need to further study the efficacy and safety of mitomycin C in prospective studies prior to its adoption for widespread use. And there are new agents that may act similar to mitomycin but have less possibility of adverse events.